There is no limit to total arterial grafting. I would first like to thank the Society for the great privilege of taking part in this very important scientific symposium. I'd also like to say it's a great pleasure and privilege to follow Professor Buxton because he is undoubtedly one of the great pioneers in this field, and his work has been very inspirational to me, both in terms of my academic and clinical practice, so I'd like to acknowledge that from the outset. I would also like to say, with the title of my talk, There is no limit to total arterial grafting, it's obviously intended to be slightly provocative. And the reality is, as Professor Buxton said, we don't have any real large-scale trials to answer this. So my talk's going to be in two parts. The first part is going to try and underpin the scientific rationale for the use of more arterial grafts, and particularly bilateral internal mammary arteries in most patients. And the second part of my talk will address why that approach may have specific advantages in the elderly. I do have some conflicts of interest. I'm a cardiac surgeon, I'm an advisor to Novadac, and I'm an advisor to Medtronic, although I don't think any of these really impact on this talk. In terms of the title of the talk, the first thing to state is there are actually a few limitations to total arterial grafting. There are patient-related factors. Obese diabetic patients, not diabetes per se, but obese diabetic patients. Those with severe chronic obstructive pulmonary disease and those on long-term steroids or immunosuppressants, because these factors all interact to impair sternal wound healing. There are also technical factors to consider. The large right coronary artery with a moderate stenosis, the only thing that works in this situation is a vein graft. If you use an arterial graft in this situation, it will almost certainly occlude due to competitive flow. There is the uncommon scenario of small caliber internal mammary arteries, and sometimes radial arteries are also inadequate. But advanced stage per se, as I will show you, is not a contraindication to the use of arterial grafts. I think it's also very worthwhile pointing out, maybe not to this audience because most of us know this, but certainly when we speak at cardiology conferences, that CABG is still the best therapy for most patients with severe coronary artery disease. It was firmly established in the meta-analysis by Yusuf and colleagues in The Lancet in 1994. I subsequently updated new studies that appeared after that, and with particular comparison to PCI, and most of these studies proved that the seminal conclusion of Yusuf was still valid in today's practice, not only for three-vessel disease, but for most patients with left main stem stenosis. And encouragingly, it's still true as shown in the 2-year results of Syntax. Now, these will be discussed in detail on Tuesday morning, and I would recommend you attend this session if possible. But what Syntax has shown at 2 years is that at least 80% of patients with three-vessel coronary disease do better with CABG, and at least 2/3 of those with left main stem stenosis. The question, of course, is this true in the elderly population? It's also important to acknowledge that conventional CABG does have two limitations. The first is the damaging effects of bypass, and this is due to a combination of microemboli, flow abnormalities, the systemic inflammatory reaction syndrome. It leads to biochemical dysfunction detectable in all organs. There is overt clinical morbidity in around 15% of patients, particularly affecting the brain, the kidney, and the lungs. And cardiopulmonary bypass mortality and morbidity are strongly age-related phenomena. And the solution to this is primarily off-pump surgery with a no-touch aortic technique, or perhaps increasingly the use of minimal extracorporeal circuits. The second main problem, the one I'm going to address today, is that of vein graft failure. We know that this occurs in 75% of patients. By 10 years, the vein graft will either be blocked or severely diseased, and this contributes to late mortality, recurrent angina, the need for reintervention in 1/3 of patients by 12 years. It's been argued that there may be better results with aspirins and statins, but that is by no means yet proven. But the solution to this is total arterial grafting. And we all have to appreciate in the surgical community that vein graft failure is still a common problem. In this paper published in the New England Journal this year, they looked at 3,000 patients, of whom approximately half had endoscopic vein harvesting and the other half had open harvesting, and the two groups had relatively similar baseline characteristics. But notice that within 12 to 18 months, 47% of vein grafts harvested endoscopically had failed, as had almost 40% of those done with the open technique. And this actually then contributed to 3-year death rates with respectively 7.4 and 5.8, a hazard ratio of 1.5. So vein graft failure is still a common problem. The authors of this paper concluded endoscopic vein graft harvesting is independently associated with vein graft failure and adverse clinical outcomes. Now, the survival benefit of a single internal mammary artery was first firmly established in this landmark paper from the Cleveland Clinic more than 2 decades ago, when they showed that 10 years after CABG, an IMA to the LAD reduced the risk of death, myocardial infarction, angina, and the need for redo surgery. And they attributed this to the fact that up to 95% of internal mammary arteries were patent at 10 years, in comparison to only 25 to 50% of vein grafts. But since then, there's been abundant evidence that the same holds true for a second internal mammary artery. It's been shown by the Japanese, by Professor Buxton's group, and by Antonio Calafiore. And this survival benefit of the internal mammary artery extends into the second and third decade of follow-up. And we can make this fairly basic conclusion that if it was not for the internal mammary artery, there would probably be no coronary artery bypass grafting today. But is there a survival benefit with 2 internal mammary arteries? In The Lancet in 2001, we published this systematic review of studies comparing bilateral and single internal mammary arteries. And from the literature, we identified more than 4,500 patients with bilateral IMA, more than 11,000 with single IMAs, and importantly, we matched these patients for age, gender, LV function, and diabetes, because these 4 factors by themselves predict likely longevity, even independently of knowledge of coronary artery disease. And we found that the hazard ratio for death with bilateral IMA grafts was 0.8, and that's a fairly powerful effect because it translates into a number needed to treat of 13 to 16 patients to 1 extra long-term survivor. Despite all this evidence, the use of arterial grafts in the UK, Europe, and United States, with the exception of a single IMA, remains stubbornly low. In the United Kingdom, we can see that 95% of patients will receive 1 single internal mammary artery, but fewer than 20% of patients receive 2 arterial grafts, and the majority of the second arterial grafts are radial arteries rather than the second internal mammary artery, and a radial artery is not an internal mammary artery. Only 3% of patients in the United Kingdom received 3 arterial grafts. And we have to ask the question, we, the cardiac surgical community, sometimes criticise our cardiology colleagues on the basis of their practice, but we have to ask ourselves this fundamental question. If a decade ago we had made the standard CABG operation 2 internal mammary arteries rather than the single IMA, would coronary artery bypass grafting be in a more secure position today? And if we ask the question, why do cardiac surgeons not perform more than 1 arterial graft, we conducted a postal survey in the UK in 2002. We wrote to every United Kingdom cardiac surgeon, and we asked them all what was their practice of arterial grafts, and 2/3 responded. 2/3 said there was evidence to support the use of bilateral IMAs. Half of the surgeons said that at least 50% of their patients would benefit. But 2/3 crucially said that if they were undergoing CABG, they would want bilateral internal mammary arteries. Yet this was at great variance with what they were doing in their own clinical practice. And the most common reason for not using them was the threat of increased mortality and morbidity. Now, increased mortality is certainly not the case. In fact, bilateral IMAs may reduce early mortality by eliminating some of the mortality due to early vein graft failure. The most worrying morbid complication is, of course, sternal dehiscence, but there is no evidence of an increase in sternal dehiscence if you skeletonize both mammaries and you avoid the obese diabetic patient. There is obviously a learning curve to using 2 internal mammary arteries, and the operation adds about 20 or 25 minutes to the conventional operation, but this is pretty small beer in a 2.5 to 3 hour operation if this really does lead to improved survival in patients. There have currently been 2 randomised trials of arterial revascularisation. The first is the Caracas trial, which was actually organised from Vienna by Paul Simon. It was conducted in 14 centres in 7 countries, and the randomisation was total arterial grafts versus a single IMA in veins. 800 patients were recruited between 1999 and 2004. The exclusion criteria were patients over 70 years or those done off-pump, and the primary outcome was MACE at 5 and 10 years. Now, regrettably, the only publication from this study has been an abstract that was produced soon after the conclusion of the trial, and there has been nothing subsequently since that. In the United Kingdom, we conducted a trial funded by the Medical Research Council and the British Heart Foundation. We recruited over 3,000 patients in 28 centres in 7 countries, and I'm delighted to say Professor Buxton was one of the key recruiters to this trial. And we randomised patients a single internal mammary artery plus supplemental saphenous vein or radial arteries versus bilateral internal mammary arteries. Recruitment ended in December 2007. This trial was powered with 90% power to detect a 25% reduction in mortality at 10 years. So that's half the effect we reported in The Lancet. What I can tell you is that the 1-year results of this trial are being currently analysed for submission for publication, but it's a remarkable observation that in 3,102 patients, the 30-day mortality was 1.2%. If we now turn to the question about advancing age, there is no question that the population and the patients are getting older. If we look at UK government statistics, we can see that the average life expectancy of a 75-year-old is now over 10 years, and that's increased from 7.7 years only 2 decades ago. Now, I would commend every cardiac surgeon in this room to try and get hold of this book. This is the 6th National Adult Cardiac Surgical Database Report. It's been edited by Ben Bridgewater and Bruce Keogh. It contains over 500 pages of data and analysis, and it looks at all cardiac surgery performed in the United Kingdom in the 5-year period 2004 to 2008. It covers all types of operations, but within it are the results of over 114,000 patients undergoing CABG in that 5-year period. And the remarkable observation is that the total mortality, including urgent and high-risk cases, was 1.8%. But if you look at CABG outcome in over 78,000 elective patients, the mortality for the whole of the United Kingdom is 1.1%. So this is a testament to the safety and efficacy of current coronary artery bypass grafting. If we turn and focus more on the elderly patients, if we look at what was happening in the 10-year period 1999 to 2008, we can see that over that period, the proportion of patients who were aged over 75 increased from 10% in 2000 to over 22% in 2008. So over a relatively short period of time, a very significant increase in elderly patients. And for CABG patients now, 25% of CABG patients in the United Kingdom are over 75 years, and 4.4% are over 80 years of age. Now, if we look actually at characteristics of 80-year-olds undergoing surgery, this is a paper from Berdacchi et al. In Annals in 2007, and they compared the baseline characteristics of over 8,000 patients over 80 years of age in comparison to younger cohorts of patients. And they found that the proportion of females was much increased at 42%. The incidence of renal failure was higher. I'm afraid these red circles have all moved a little bit, but the basic points to try and make is that there was a far higher incidence of carotid disease. Notice that 34% of patients had left mainstem disease. Notice that 2/3 of patients underwent urgent coronary artery bypass grafting, and note that the rate of off-pump surgery was 32%, significantly higher than in the younger cohorts. Now, if we go back to the UK data, this looks at CABG mortality in age in over 112,000 patients in a 5-year period. And what you can see is that CABG mortality, not surprisingly, increases with advancing age. In patients under 60 years of age, the overall mortality is less than 1%. But if we look at the group, the 75-year-olds, I'm disappointed in the colours they chose to make these beautiful slides, but nevertheless, this is the 75-year-olds, and these are the 80-year-olds. And you can see that in the 5-year period, mortality in 75-year-olds has fallen from 4% to 2.8%, and in patients over 80 years of age, from 8.2 to 5%. If we go back to the Bardacchi paper and look at the morbidity following coronary artery bypass grafting in patients over 80, the incidence of stroke is 3%, the incidence of reoperation for bleeding 2.4%, renal failure in 2.5%, but notice also 7% of patients had respiratory failure. If we look at duration of post-operative stay in over 107,000 patients in the United Kingdom, the mean post-operative stay in 80-year-olds is 12 days, so almost double that of patients under the age of 60 years of age. And these figures are almost identical to what's reported by Bardacchi. The mortality in patients over 80 years of age, 5%, and the length of hospital stay, 14 days. Now, Bardacchi made another very important point. When you looked at the discharge of 80-year-olds from hospital, if you were under 50, 96% of patients went home. But notice, in the over 80 population, only 50% of patients were discharged to home care. If we look at intermediate-term survival at 5 years, it's not bad for patients over 80. Almost 70% of them are still alive at 5 years. And this again mirrors the results from the United States. If we look at the survival of octogenarians in the United States, it's almost 60% are alive at 5 years. If we look at the patients who have had coronary artery bypass grafting, it restores this population to that of normal age and sex-matched controls. Now, if you look at complication from CABG, the most worrying thing is undoubtedly new post-operative stroke. In the UK, in over 95,000 patients, we can see that the incidence of stroke for elective first-time CABG is 1% in 2008. So that is very similar to what was noticed in Syntax in the immediate peri-procedural duration. It was just 1.3% in Syntax. However, if you do have a stroke, it increases your mortality from under 2% in patients without stroke to somewhere between 8 to 16%. It, not surprisingly, significantly increases hospital stay by threefold, from 7 days to 21 days, and it significantly impacts on long-term survival. Now, patients who have strokes already have higher risk factors in any event, but the addition of a stroke also further decreases their long-term survival. And if you look at the risk of stroke, it is absolutely proportional to the burden of aortic disease. I've summarised 9 studies here involving almost 5,000 patients looking at the impact of aortic atheroma on the risk of stroke. And every single one of these studies shows that aortic atheroma is the best predictor of stroke. If we're trying to find aortic atheroma, epi-aortic ultrasound is much better than TOE, which is much better than manual palpation for detecting atheroma. But all of these studies showed in one form or another that modification of aortic manipulation reduces the risk of stroke and cerebral microemboli. And this is consistent with the fact as shown by Newman in Circulation in 1996 that advanced age and therefore more aortic disease is the strongest predictor of stroke. Now, if we look at what this means for us in practice, here are a number of cartoons of possible ways of revascularizing the heart. The first shows the conventional mammary artery and 2 vein grafts. Notice, obviously, the vein grafts have to be attached to the ascending aorta. Here's a composite bilateral IMA to the left side with a radial artery again attached to the aorta. But in my own practice, most of our CABG operations are based on this technique, 2 in-situ mammary arteries. We use the left mammary to the obtuse marginal. The vast majority of these are done off-pump. And we keep the right internal mammary artery and cross it to the LAD. And we tend to take composite grafts from the internal mammary arteries. So that allows us to do these operations off-pump and without touching the aorta. More recently, we've adopted this technique, which is preserving the in-situ mammaries, the left mammary to the obtuse marginal, the right mammary to the LAD, and then we take the radial artery from the distal LAD, run to the PDA, as long as there's significant disease in either the right coronary artery or the PDA. And this is a fairly straightforward operation, and I think it has an advantage in that it avoids the technical problem of anastomosing radial arteries to internal mammary arteries, where this causes a potential problem of Steele syndromes. Does this actually reduce the risk of stroke? This is a paper by Calafiore of almost 5,000 patients. They looked at 2,800 done on pump, and with the conventional cannulation, cross-clamp and side biting, the incidence of stroke was 2.3. By using composite arterial grafts on pump and avoiding the side biting clamp, you reduce the overall risk of stroke by 1%. In almost 2,000 patients done off pump, the use of just a side biting clamp caused a risk of stroke of 1.1%, and the avoidance of all of these manipulations of the aorta, just using a no-touch aortic technique, brought down the risk of stroke to 0.2. That has now been confirmed in several other studies in the literature. And if we look at large databases of off-pump patients, Wasundra and Jack in 2005 looked at 268,000 patients and found that those in propensity-matched patients done with off-pump surgery, the hazard ratio for stroke was 0.6. Hannon looked at almost 50,000 patients from the New York Registry, the hazard ratio for stroke done off-pump, 0.7. And Puskas, in a paper published in Annals this year, looked at 42,000 patients, the hazard ratio for off-pump surgery for stroke, 0.65. So remarkably consistent figures about the reduction in the risk of stroke just by doing these patients off pump. And I have to emphasise, most of these did not use a no-touch aortic technique. So the results would be even better if you avoided all aortic manipulation. So to summarise and conclude, I think today we can say that arterial grafting should be the basis of most coronary artery bypass grafting. And there is, as I've shown you, still continuing evidence of high failure rates of saphenous vein grafts. I believe that over 90% of CABG patients should receive two internal mammary arteries because the best available evidence suggests that there is a survival benefit for this operation, and particularly in younger patients. Where you have to be cautious with this approach is in the obese diabetic patient, those with bad lungs, and those patients on steroids or immunosuppressants. We have a rapidly growing elderly population undergoing cardiac surgery, and these patients are at significantly increased risk of both death and CVA. I think the current evidence shows that by having the basic component of the operation in this population, bilateral internal mammary arteries, this permits off-pump surgery, which itself reduces the risk of death in this population, and it also permits a no-touch aortic technique, which significantly reduces the risk of stroke. On that point, I'm going to conclude my talk. I would like to thank the organisers again for the very great privilege of taking part today, and the audience for your attention. Thank you.